Hi, everyone, and welcome to the third episode of the Practitioner Edge podcast run by the Nutrition and Health Collective. I'm so glad to be here. I am the founder of the Nutrition Collective. And today I'd like to give you a sneak peek, not just on what's to come at our conferences here at the Nutrition Health Collective, but truly to introduce you to two brilliant minds in nutrition and functional medicine. I'm thrilled to introduce you to our speakers today, Dr. Carrie Jones, who is a globally renowned healthcare professional and female health expert. And I'm also delighted to introduce you to Dr. Kristi Hughes, who has over 30 years of experience as a practitioner and over 10 years at the IFM as an educator. And we're also thrilled to let you know that she's on our advisory board for the Nutrition Health Collective, shaping our conferences, shaping our education, and truly giving all of you a deep dive when it comes to the world of nutrition and functional medicine. I'm so excited to have both of you here today with me.
Thank you. I'm excited to be here too.
Oh, this is great. It's amazing to watch you grow and expand around the world, Romina. It's wonderful to always take the stage with you and the amazing practitioners that you bring together for these events.
Thank you, Kristi. I think we had such a brilliant time in Dubai that now we want to make the magic happen in London as well and truly bring a deep dive to the practitioners, to the healthcare professionals, so that we can make a difference and an impact in our community. I'd like to start with you, Kristi, because you have helped shape the day at the Ultimate Metabolic Health Conference, which takes place on the 17th of May in London and virtually. And I'd love for you to give us an insight on how did we shape the day, why did we shape the day, and why does metabolic health, focusing on and zooming into women's health, why is that important for healthcare professionals today?
I think the thing that's really becoming quite clear and is emerging not only in the science but in clinical practice is we are finding that the needs for women's healthcare are finally front and center. I mean, we acknowledge that over the last 50 years, women have been underrepresented in the studies. We haven't had good clinical data. And honestly, it's been sort of spaghetti on the wall often, with strategies for, how do we deal with and support women? And today, what we are recognizing is women have very unique and very particular specific functional needs when they're in their menstruating years, those years that they are childbearing. But things shift drastically as they start to move into the perimenopausal window. And then once again, once they are menopausal, not only are their physiologic needs and hormone needs necessarily different, but so is their personal training and their fitness needs. Everything from how their mitochondria behave to their cardiovascular needs, all the way upwards of looking at neurology. We are seeing such unique, specific needs that women have at different ages and at different stages. So kind of quite frankly, I think this is where root cause medicine, foundational nutrition and integrative medicine shine, because it is not a one size fits all or one age needs this protocol kind of a situation. We've got an advancements of laboratory testing. We've got a much stronger understanding of not only how do we make hormones, what happens if we take hormones, but what is so important is how do we get rid of them at the end of the day? Right? Regardless of where they're coming from, we still have to metabolize them well. And some of those needs and those concerns are different in the ages and stages. So what I'm excited about, in this conference is we've got remarkable speakers coming in to really shine the light on some of these different needs, unique aspects. And sort of, we all would think about metabolic needs and think, yeah, well, let's talk about glucose and insulin and the trajectory that we see with the metabolic syndrome and some of these relationships back to insulin resistant complications. But when we really step back and think about the whole metabolic picture, there is an important interplay here with adrenal thyroid. There's such an important understanding of the gut and the gut microbiome. And we understand the role of taking us back into the inflammatory inflammation and even the autoimmune realm. So what I'm looking forward to in this conversation is, there are some sort of staples that we're going to be thinking about in all women in all ages. But I'm really excited that we are going to take the time to drill down deeper into some of these unique windows of time for women and really shine the light on and highlight clinical acumen and some of the specific ways that I think the nutrition market, the integrative medicine market, the naturopathic market clearly, and those whose focus is on root cause care, this is really our moment to shine for those of us who are taking the step of N1 medicine, right? Again, thinking about the N of one one woman sitting in front of you telling their unique story. There really is an art and a science to helping women with healthy hormone balance.
Absolutely, absolutely true. And I think this is such a critical conversation to have because, as you said, we've been talking about metabolic health very generally, but we haven't had this focus on women's health and understanding how does it actually impact you. And the detoxification piece for me is phenomenal because, as you said, we're detoxing, we're retoxing, we're taking hormones, we're taking out hormones. And I think the fact that we have a hormonal expert like Dr. Carrie Jones with us is truly to walk us through this journey of the woman who's menstruating up to a woman who's going through her menopause and to actually age gracefully and, really truly bring that to light. Carrie, why do you think this is such a critical conversation? And how do you see a woman's metabolic function evolve through time?
Oh my goodness. Honestly, to add on to what Dr. Kristi Hughes said, and as the popular saying goes, women are not small men. And who we are in our cycling years, well, first of all, who we are going through puberty is not entirely the same as who we are in our cycling years, and definitely not the same as we're going through perimenopause and crossing over into becoming postmenopausal. As I've been reading more and more researchers who are getting into metabolic health in women, thank goodness, it's understanding even little things such as the enzymes that release fat slow down, the ability for our little factories, our beta oxidation, to break down the fats that do get released slow down. Where we store fat changes. How we handle insulin and glucose completely shifts. And I think this is really important to know because I think so many practitioners or even just women listening themselves get to a certain age and go, I didn't change anything, and yet everything changed. My body looks different. I feel different. My energy is different. And metabolic health affects not only glucose, insulin, weight, etc., but it affects how things do or don't grow. So even think about your hair, even think about your skin turnover, your energy. If you don't have great metabolic health, then you're going to feel tired. You're not going to have the oomph, the energy, and the resources to grow thick hair, to have beautiful skin, to feel good. And I don't mean this from a vanity standpoint at all. I absolutely mean it from a prevention standpoint, an improvement standpoint. So teaching about metabolic health through the ages is necessary, one, just to feel better, and two, because of the prevention part. As Dr. Kristi said, it's like getting to the N of one, the root cause medicine, and that's truly what it is.
Absolutely. And I think when you talk about women's health in general, I think you can't apply the small men theory, as you said, because since 1993, we haven't had any clinical trials done on women. And so, all of that information is skewed. It's only in the last 20, 30 years that we actually have good quality information to share. And Kristi, I want to go back to you because I think that you gave us a very good idea for the conference, which was, yes, we're going to be talking about, the theory, the foundation, the core of what we need to understand when it comes to, this whole hormone metabolic, axis. But what about using this, in clinical practice? As practitioners, everybody's always craving clinical outcomes. We're looking at implementation. Tell me more about the session you're going to be hosting with Joe Gamble on this clinical implementation when it comes to women's health.
Yeah, we're going to talk about cases. And I think one of the important things to, again, put front and center when we're talking about women who are in their midlife years, right, is these are the years where it's really imperative that we understand the relationships taking us back to estrogen metabolism and detox. Right. So understanding what an important role. I mean, it has been going back to the Susan Summers era, right? If we kind of look back over the last 20 years, I mean, the conversation around estrogen dominance isn't necessarily new, but some of the tools in our toolbox and some of the relationship components that come back looping in the microbiome, some of the challenges with different types of gut microbiome alterations. I mean, quite frankly, even the era of coming through the COVID pandemic caused a lot of changes, interestingly, for a lot of women's healthcare needs. I think it's kind of remarkable that those suffering from biotoxins or dealing with mold challenges can also have these impacts with their estrogen receptor sites, right? So for these women going through their midlife years, it's very much coming back down to liver performance, estrogen metabolism, understanding the gut microbiome, putting this extra level of emphasis on stress and adaptations to stress, again, like our adrenal thyroid axis and the cascades that follow. But this is also a window of time where we got to be mindful about sleep and recognize the regenerative needs for women, and making sure that we are putting into play key factors that are cognitively preventive, right? So, oh my goodness, I remember the very first data I saw from Joel Evans, a well-renowned, OB-GYN doc. And this is like 20 years ago when I was starting to have kids, and I had 4 kiddos, right? And I remember him talking about when women are going through pregnancy and into what they call 4th trimester, right? Those first 3 months when they're nursing their babes, that there were like visuals, understanding from an imaging perspective that if moms weren't getting the right food, nutrition, essential fats, good oils, and sleep, that their brains were actually shrinking throughout the course of their pregnancy. I mean, that was a big aha moment for me, when you sort of think of the postprandial brain and the exhaustion that follows. So kind of the dance that women need and understanding food, nutrition, stress, and sleep is key. And I think what Joe Gamble and I are really going to also then focus on is it's a very different story when we flip over and we're starting to dig down into those menopausal years. Because interestingly here, one of the most important biomarkers that we have once we stop menstruating is our muscle mass. It's being mindful about sarcopenia and recognizing that this whole shift that Dr. Carrie was alluding to that is so correct, like how we store body fat, metabolically how we burn, all the way to how do we put on muscle and the importance. When I sit with women who go through perimenopausal changes, and some of them in my practice I've known for 30 years, which is kind of amazing to have sort of walked with them and myself through this process. I'm finding like I'm coaching them to training. I'm coaching them to get in the gym. I'm encouraging them to like get off the track where they've been like walking for fitness and doing this cardio piece where they're out walking 90 minutes at a time, and saying, look, this is not the era for the walk and talk. This is the era for you to get in and start lifting heavy. This is where like you need to learn a whole new way of strength and maintenance. So the menopausal years, quite frankly, that's not the time to start pressing heavy on estrogen metabolism. We're trying to like preserve and hold on to the amount of estrogen that is there, and we're trying to replete estrogen that may have been lost. And often if you're doing some of the same strategies you were using in your menstruating patients and you're driving estrogen metabolism, you can actually be pulling estrogen levels down low too quick, too fast. And women start flushing. They start having night sweats. They start dealing with this sort of accelerated estrogen deficiency type state. So, I think the order is important, and understanding the needs is really different, because in the menopausal woman's era, your whole focus is strong bone, healthy brain. You're going to be thinking about neurologic complications and strengthening neurology. But this is also an era we're talking about hair, skin, and nails, and so much is coming back to healthy aging and healthy vitality that is there. So, the emphasis has really changed. I mean, it's not uncommon to talk about hormone replacement therapy, which I'm a huge fan of. Bioidentical hormone replacement therapy has found a very safe and incredibly impactful place in the world for women going through these changes for their brains, for their heart, their cardiovascular system, their bone, etc. But the conversation really is very widespread, and it is a conversation around vitality and whole wellness.
Absolutely. Absolutely. This is the reason we want to go through this journey between, what are the actual needs for women who's menstruating, what are the needs for women over 40, and what are the needs for postmenopausal women, and what kind of support do they actually need in those experiences. And you talked about biomarkers, looking at sarcopenia and muscle testing, Kristi, but, Carrie also talks about testing in general. And this is one of the reasons we're going to have the Dutch test being done as well. And I'd love Carrie to take us through why should we be looking at testing?
Well, honestly, I'm such a big fan of testing, which is very interesting because testing seems to be quite controversial on social media. If you'll see, there are a number of experts who feel that you don't need to do any testing once a woman, let's say, hits over 40 or hits over 50. And I just think that's a real disservice in a lot of cases. While it's true you don't need a test to tell somebody if they're perimenopausal, it's first of all not a disease that, all women will go through it. But testing can give us so much feedback. So the Dutch test in particular will help give us information around their estrogens and progesterone, but also, as Dr. Kristi said, estrogen metabolism. So you make an estrogen, where does it go? There are different routes and paths it can go down. Some are much better than others. And if we're trying to reduce risk and support prevention and long-term care, then obviously we want to be encouraging somebody go down a particular path through diet and lifestyle, nutrition, etc. It also looks at ratios, which is something I have become a big fan of, especially in regards to metabolic health. There has been for a while, but it's making better news, the look between testosterone and estradiol. And especially as women get older, testosterone doesn't tend to fall as quickly as estradiol does. And what can happen is women can feel what we call as androgenic. So they can start putting on that weight around the middle. They can start developing a lot more visceral fat. They notice their chin hairs are stronger. Their hair loss is more. They're getting acne, like they're going through puberty again. And then what happens is because maybe they're afraid of estrogen, or their practitioner who's prescribing is afraid of estrogen, they put them on testosterone. And now they have this complete imbalance. And so I want to talk about some of these nuances of when you're doing hormone replacement therapy, maybe what order should we do it in? What should we be looking at the Dutch test of looking at testosterone versus estradiol, or the way that testosterone breaks down into its metabolites, some which are much more potent than others. And then, of course, the adrenal aspect, which Dr. Kristi talked about. We have to consider the HPA axis, the hypothalamic pituitary adrenal axis, at all ages, and especially for women who are struggling with metabolic health and when they're getting older, older than 40, older than 50, because that change in hormone also impacts the way their nervous system works, impacts the way they handle or produce cortisol, norepinephrine, and epinephrine. And then lastly, as part of the Dutch test, one of my favorites is it looks at melatonin. And a huge researcher in melatonin, Dr. Russell Ryder, was like, once you hit about 50 years old, your natural melatonin production out of your pineal gland goes down. And we, of course, think of melatonin with the circadian rhythm, which it's absolutely key for. It's also a super powerful antioxidant. And we need that to continue as we get older. We need to support our melatonin. So it's nice to have the Dutch test to get the comprehensive look of what are your hormones doing, where are they going, and in what pattern is your cortisol throughout the day.
Absolutely. And I think we definitely shouldn't underlook or, overlook that kind of factors when you're actually having a patient coming to your practice, you looking at that particular issue that's going through, because sometimes, some women may not detoxify properly, but as you said, sometimes it's a testosterone problem. There's an overproduction there. So it's so interesting to understand how you work. And this is what we find very, very, very powerful in the conference, is that we're going to have both of you there. Both of you are going to have your own lens, your own kind of way of working, and how do we actually merge that information as a practitioner to make it very practical for us when we have patients coming into practice. And Kristi, tell me more about what kind of challenges or clinical patterns are you seeing right now when it comes to this metabolic and hormonal dysfunction?
Well, I think it's interesting to see that sequential change correlate over to cardiovascular adjustments and also dyslipidemias, right? And I think it's such a fascinating conversation, and women will panic. They'll go in to see their GP 1 year, 2 years after that last menses, and they're walking out the door with a cholesterol that, of course, here in the States is reading, in our empirical units, 220, right? And they were always trending at 190, and now they're up to 220, and there's a little bit of a bump in their LDL, and oh my gosh, there's this sort of panic that happens. And I think this is such an important story for women to understand about themselves, that there are going to be some adjustments and there are some patterns that will shift that don't carry with them increased cardiovascular risks, that don't carry with them some of these tendencies and these challenges where increase for stroke and heart attack might be present. Because quite frankly, a lot of the labs that practitioners are tracking are not even the right biomarkers for looking at lipid disorders. So I'd say one of the things that I think is just really an imperative story to be told that women are understanding is it's not uncommon. As a matter of fact, it's more common than not that as you cease to menstruate and you move into that menopausal window of time, your lipids are going to shuffle around a little bit too. and to know that there are subfractionated lipids to be considering, subtypes of LDL. There's important types, apolipoproteins play a role, and kind of keeping an eye on metabolically the triglyceride levels, right? And knowing that, if you're gaining a little bit of weight around your midline, well, go back and also think about, well, could it be stress and cortisol? Could it be insulin resistance? What other lab or biomarkers are there to help us understand if it's inner belly fat or outer belly fat? In the healthcare world, we call that visceral fat or subcutaneous fat, right? But, changes in the midline can give us such great clinical correlation if we tether them back to when we look at labs, right? So if the triglyceride level is bumping up and the HDL level is going down, and this woman is starting to have changes in her waistline or her waist circumference, we may want to have a conversation about insulin resistance, order specific labs, teach her how to change her diet and lifestyle in a way that she's able to control her glycemic impact and keep her insulin and her inflammation levels down. Which may be a whole different conversation with a woman who is noticing that she's storing more of her weight down around her thighs and below her waist, and her LDL levels are really starting to spike, and her apolipoprotein B levels are starting to creep up. And then then we better know to go in and look more carefully at the thyroid. And we may want to do some extra nutrition physical exam elements by just even simply looking at lateral eyebrows. There's such fun, interesting things when you do nutrition at that level of N1 cause, knowing that there's going to be this sort of carryover that's going to move through those transition years for women. And we want to be predictive. We want to get in front of it, right? We want to be able to identify some of those patterns years before those trajectories shift.
Absolutely. Absolutely. I love the way you zoomed into cardiovascular health and cholesterol, because it's often overlooked and it's very much a male's disease, but we're not looking at this more carefully. Carrie, do you agree? What are your thoughts on this?
Yes, actually, I always say to people that heart disease is the #1 killer of humans, which includes women in there. And I was silently laughing to myself, Kristi, because I have had more women tell me, I'm not quite 50, but I'm almost 50, but I've had a number of my friends who are in their 50s go, I used to have normal cholesterol my whole life. I had normal blood pressure my whole life. And then I turned 50 and all of a sudden, right? Or I turned 52 and all of a sudden. And I hear that more and more. And instead of investigating further, looking at hormones, looking at thyroid, looking at stress, looking at inflammation, looking at diet, lifestyle, etc., it gets chalked up to aging, and here is a statin medication, and no other information is often given, which is so frustrating. And so I think it's important to have that conversation to really open women's eyes to, it can definitely increase. Here are a lot of reasons it can increase. Here's the difference between triglycerides increasing or insulin increasing versus, your small LDL particles increasing and apolipoprotein B, etc. What does that mean? And then honestly, how can we be proactive about it? And I also love that you said, let's get in front of it. It's the same that I feel about DEXA scans for bone. DEXA scans don't even start for most women until their 60s. I'm sorry, what? And it's the same for heart disease. I'm like, why are we not getting at least some baseline readings? Sometimes a GP will say, all right, let's do cholesterol. I mean, we might as well do a cholesterol on you, here and there every 5 years. And I think, no, that's such a disservice, because you can catch pretty quickly when it starts to go up. I think we should start younger rather than later for a lot of these things.
100%. We should start younger rather than later. I love that. That should be our mantra with our patients. Absolutely. Kristi, I wanted to ask you, because, you've helped us shape the day, and that we're going to have Dr. David Unwin as well speak generally about glucose monitors, about the importance generally of monitoring blood sugar levels, insulin resistance. Can you give us a little bit more of a sneak peek around that?
Well, I think the work that he's doing, that he's going to bring to the stage for all of us to really learn from, is the power of implementation, and to recognize that these new tools that we have in our toolbox, let's be direct as we can. Diabetes levels are not going down. Pre-diabetes levels are escalating. I mean, we are seeing such an important relationship coming back to diet and food and stress and, quite frankly, metabolic toxicity, right? Where the toxic burden is compromising our overall blood sugar regulation, that some of these new tools that we have in our toolbox, and the use of using a continuous glucose monitor, which he's going to really shine the light on and talk about his success story, I think I saw it scrolling in the last day, a comment about, oh, how could you ever recommend, or could a doctor ever recommend a CGM to a non-diabetic patient? Right. And it's like, that is again getting in front of it, right? And just giving people a sneak peek opportunity to see, how does their body dance with their food and their nutrition and their movement and their sleep, right? Because sometimes the same meal that somebody is consuming, which may have a low glycemic impact to it, is going to have a different effect overall based on sleep and movement in comparison to sedentary behavior and lack of sleep and lack of restoration. So what I'm excited to hear about is their clinical success. His team and those that he works with have great data that they are going to report and they're going to share. And what I love about the tools in the toolbox are, it really helps encourage the patient, that the subtleties are there, that their uniqueness is there, that sometimes we do want to sort of peer under the hood a little bit more to get a sense of how does that unique individual respond? Because quite frankly, people tend to dig in and take higher level responsibility. They're more motivated to transform their patterns or really look at habitual diet and lifestyle patterns that maybe have been going on for 10, 20, 30, 40, 50 years if there's data. Like sometimes that little bit of data makes all the difference. So I think not only is he going to show up with the science and really show us the why and what are we learning in our new era of pre-diabetes, right? But I think what I'm excited about hearing, and I always love to glean those advanced clinical pearls, kind of like, well, how did you say that to the patient? And is there another analogy to use? And is there a way to frame that conversation? Because I think where a lot of this gets lost in clinical practice is not in the knowledge that the healthcare provider or the nutrition professional has, but it gets lost in the conversation of translating what the doctor knows into the patient or the client, implementing those steps and being able to walk away with a real plan and the inspiration to be able to make it happen. So I'm looking forward to what he's going to bring to that discussion of implementation, and what is it that we can do, to help our patients. Sometimes it's just the framing, it's the language, it's the analogy, or hearing, how does this patient learn? Are they going to do better with just a list and a handout and don't overtalk it? Is this a patient that has an emotional connection to food? And we really need to process the relationship that they have with certain foods, because it goes back to sitting in grandma's kitchen and the relationship they had when they were nurtured. And I think it is so imperative that we meet the patient where they're at, because the same treatment plan and the same lifestyle guidance suggestions can be rolled out so uniquely and differently. And I think that's half of the success that we get in clinical practice.
And we really underestimate the role of compliance, communication, and accountability that we need to have with that patient, with that client, communicating with them and making sure that they've understood, as you said, how do they actually put this in practice? Is it overwhelming for them? Or as Dr. David Unwin says, are there ways of communicating with them? And I know, Kristi, you love working with health coaches as well. So I'm just throwing that in to say, there's a whole other world out there when you're actually communicating with the patients and the clients and finding ways to make them accountable and comply with some of these suggestions.
I'm really biased about it. I have seen such a shift in the landscape in this field in 30 years that when I see either a practitioner who learns coaching skills, because they are skills and it is a mindset. There's no question in the 90s and the 2000s, there was still the mindset of doctor dictator, right? Where the doctor knows best and the doctor will tell you what you need to do. And they're going to give you the handout, or now we're going to give you the app that tells you what to eat and what not to eat. And there's patients fall short. It still doesn't work, right? And the art of coaching, the art of conversation, I am a little biased. Naturopaths are trained a little bit more heavily in this arena, but I think it's really important that we are seeing this incredible swing towards healthcare providers who want to seek a stronger language and skill set. And I do think that if you as the practitioner don't want to handhold, or you're not great at having the emotional conversation around food, or you don't want to hear about the trauma that's holding them back from making those changes happen, then you really need to have a strong referral network around you. You need to have a collaborative care team. And I'm a huge advocate for practices, especially busy doctors, hiring and bringing in a well-educated nutrition professional, bringing in a well-trained functional medicine health coach, because they do have the skills. They have the patience, they have the time, and they are the ones who are designed to be a part of this clinical team to be able to make sure that that client is accountable to their own goals, but that patient client is accountable back to the doctor's needs, right? Because the doctor's goals are not always the same as the patient's goals, right? The goals that they may have for themselves. So I think one of the important things that we need to responsibly think about in a clinical arena is you have a patient who has their own set of desires, goals, and intentions. You have the doctor with a medical responsibility to get those triglycerides down, to get those apolipoproteins down, to help that patient, balance their blood sugar and shrink their inner belly fat. But those goals are not always the same thing. And so by bringing somebody onto your collaborative care team, whether it's a health coach, it's a nutrition professional, it's an MA, it's a nurse, there's amazing practitioners that can round out that office team to make sure that the patient leaves equipped with the ideas and the inspiration to make it happen.
And I'd love us to have this collaborative care team all across the world where, all of these different practitioners are working together and truly, giving the patient the best care possible, but also working together as a community. And for me, that's been one of our goals at the Nutrition Health Collective, to truly create that community. And hopefully we can make that happen at the Ultimate Metabolic Conference. Carrie, I want to end with one last question with you and ask you, what would be one common misconception around metabolic or hormonal health that you would like to share with practitioners at the conference?
One of the big things that I hear a lot on social media is that it's only calories in, calories out. That's it. And I think any person in the whole world who has tried to get their metabolic health under control, lose the visceral fat or lose just fat in general, maintain their muscle, knows it's not just calories in and calories out. There are a lot of our patients, a lot of our clients who have tried that. They've stuck to the apps. They've recorded everything. They have undercut calories, and yet they can't figure out why their triglycerides are high, why their blood pressure is high, why they have been gaining weight, why they're so tired, why they're losing muscle. It is definitely, let's call it a collaborative effort between calories in, calories out, coupled with a whole lot of things around hormones, estrogen, progesterone, stress, obesogens, which are the toxins that can contribute to the different forms of weight gain, to past medical history, to genetics, to adverse childhood events, trauma. I mean, there's a lot that goes into how and why and where you store your fat, your mitochondria function or don't, etc. And so that's probably the biggest one that I want to just take a big eraser and erase. It's the whole point is not calories in, calories out. Might have worked when you were 22, but as you get older, I think a lot of people can raise their hand and go, yeah, that's not working anymore.
Absolutely true. It's just a different way of doing it. And I loved what Kristi mentioned before. In your 20s, your LDL, your hormones, your cholesterol are going to be at a different level. Once you hit your 40s, it's a whole other story. And this is where we need to be geared to support our patients, our clients, to have to be the best versions of themselves at that age.
Yes.
And, it's never too late. So for me, that's a very important message for all of them. It's never too late to help our patients and our clients thrive.
Absolutely.
I wanted to also mention that at our conference, we'll be having Joe Gamble, who's the UK's first functional medicine practitioner as well, who's going to do an implementation session with Dr. Kristi. And I'm very excited about that because I think it's going to be one case study and we're going to have two different lenses of, strategies and, implementation protocols coming into that implementation session.
Say, dust off your sex steroid hormone cascades, because I think this whole day is going to be a lot of fun coming back to the chicken wire diagrams, right? And remembering, right, that it all starts with cholesterol, right? It starts with oxidized LDL and cholesterol, and that whole entire downstream flow that we're going to work our way through is so imperative. And so as painful as that was to study and regurgitate the first time, I think it is so practical. It is so necessary. And I'm just really excited to be learning from all of the practitioners coming, especially you, Dr. Carrie.
Well, and guess what? That cholesterol, where does it start? In the mitochondria, right? So we have to have healthy mitochondria to even make the first step happen in the first place. So we are absolutely going to talk about that. I can't wait.
I can't wait either. And I hope all of you listening, if today's conversation has sparked your interest, do join us. And you don't want to miss our Ultimate Metabolic Conference taking place on the 17th of May in London or virtually. And as we said, some of the topics include women's metabolic health across the lifespan, run by Dr. Carrie Jones, Nutritional Strategies for Type 2 Diabetes Remission by Dr. David Unwin. We're going to be talking about advanced hormonal testing for perimenopause, menopause. We're going to have real-world case studies and implementation tools with Dr. Kristi and Joe Gamble. And we're going to have a deep insight into CGMs, nutraceuticals, testing panels, and so much more from today. I'm so excited to have you both with us next month in London, and we are so grateful for your presence and for your knowledge. We hope it's going to be a huge, beautiful event that we're going to be creating together. Thank you, both of you.